Previously, we discussed the temporal and infratemporal regions of the head and neck. Here, we'll discuss the pharynx. I wonder how many of you have walked by a pharynx and have been tempted to throw or have thrown trash into it. What, you're going to tell me you've never done this? Well, let me show you a pharynx, and here's several, and look where they're located on the upper deck. What, you don't recognize the pharynx? Let me zoom in on them, and now tell me that if you walk by one of these, you would not be tempted to take the gum out of your mouth and send it down the tube. In case you do not know, let me tell you this would be incredibly rude. Those pharynx, you see, are there for one purpose, to bring up dry, dull air from the hull of the ship. Mates are down there in the hull working on the ship, and any trash that ends up there makes their lives miserable. So if this is a pharynx, where is our pharynx? And here it is. It is a fibromuscular tube that is open anteriorly. It extends from the base of the skull until reaching the cricoid cartilage. It is the area indicated in blue. If you zoom in and look at the walls cutting cross-section that make up the pharyngeal tube, you can see that the inner lining is made up of the mucosa of the pharynx, connective tissue fascia, and striated muscle on the outside. These are called the pharyngeal constrictors. The constrictors are actually quite prominent, and there are three: the superior, middle, and inferior. Gaps in between the muscles allow for nerves, vessels, and even other muscles to pass through the walls of the constrictors to enter the pharynx. Let's now move back to the pharynx. Now, if it had been up to me, I would have stopped with the labeling right then and there. But no, the original anatomists had nothing else to do, so they went further and subdivided the pharynx into different regions. If the pharynx was posterior to the nasal cavity, it became the nasopharynx. The pharynx located posterior to the oral cavity became the oropharynx. And I guess you can see what's coming. The pharynx located posterior to the larynx became George. Okay, that last one was a dad joke. It is not called George. Let's now discuss the prominent structures we find in the different regions of the pharynx, and we will start with the nasopharynx. The roof of the nasopharynx is the base of the skull, and located there is tonsillar tissue, the pharyngeal tonsil. This is not the tonsil that you think about when you think of the tonsils, but it's lymphoid tissue, and they become inflamed, and when they do, they become known as adenoids. But now look what is just below the pharyngeal tonsils, the opening of the auditory tube, also known as the eustachian tube, which connects the nasopharynx to the middle ear. Now realize what can happen in a child who has developed adenoids. The infection may travel from the nasopharynx to the middle ear, and if left untreated, it can lead to deafness, a condition that is more likely in children than in adults because of the relative position of the auditory tube to the middle ear in children. Let's explore this point further. In this drawing of an adult, note the relative position of the auditory tube to the middle ear. Observe that the tube is nearly vertical. Now look at the situation in the child in comparison to the adult. Note how the auditory tube is nearly horizontal in the child. Infection from adenoids could easily travel from the nasopharynx to the middle ear by this horizontally located tube. As shown in this drawing, the infection resides proximal to the eardrum and is unable to dissipate because the auditory tube is blocked by the infection. Consequently, the treatment for such conditions is based on the rational approach that the fluid must be removed to avoid deafness, and it is done by the placing of tubes to drain the fluid to the outer ear, as shown in the slide. In time, as the child grows and the auditory tubes become more vertical, children outgrow their need for the tubes. Let's now go to the oropharynx, and it is here where we encounter the palatine tonsil, the tonsil that you, or you may know someone, had them removed in a procedure known as a tonsillectomy. The opening of the oropharynx is guarded on either side by a palatine tonsil, which consists of lymphoid tissue. As you see in this adult cadaver, the palatine tonsils are difficult to see. The reason is that they become involute as we age and become nearly invisible in adults. Try and see if you can see your own by shining a light into your own oropharynx and looking in the mirror. Further, the palatine tonsils sit between two arches. The one between the palate and the tongue is known as a palatoglossal arch, and the one between the palate and the pharynx is called the palatopharyngeal arch. If you wish to see the difference between normal and inflamed tonsils, here's a comparison. Here are the palatoglossal arches, and here are the normal and inflamed tonsils. Although the pharyngeal and palatine tonsils are the most prominent of the tonsils, in reality there's an incomplete ring of tonsils guarding the pharynx. The other two that I have not yet mentioned are the tubal and lingual tonsils, and the four tonsils form what is known as Waldeyer's ring. These tonsils are all prominent early in life, but greatly reduce in size and diminish in size after the teen years. Tonsillectomies were rather common procedures in the 1950s and 60s, and it was considered a nearly benign surgical procedure. Indeed, kids would look forward to it as a chance to be fed plenty of ice cream. Also, whereas previously tonsillectomies were mostly performed for recurrent infections, now it is about 20% for infection and 80% for obstructive sleep problems. As shown in the left panel, the mucosa of the tonsillar bed was excised, the tonsil identified, then, as shown on the right panel, the anterior border of the tonsil was freed, the superior part that extends into the uvula was shelled out, and the mucous membrane of the palatopharyngeal arch removed. Complications were rare and tended to be due to small arteries located deep to the palatine tonsils, such as the tonsillar branches of the ascending and facial arteries and the corresponding veins. But on rare occasions, the hemorrhage was due to perforation of the internal carotid artery, resulting in death. Indeed, the incidence of mortality after tonsillectomy is a rare condition, estimated to range between 0.1% to almost negligible, and almost 30% of the deaths were mainly related to the hemorrhage secondary to a lesion of the internal carotid artery, the external carotid artery, or one of its branches. How can this be? Look again at the posterior relations of the oropharynx in this dissection of the pharynx. Note the location of the internal carotid artery and the reflected internal jugular vein. Both run just deep to the thin layer of muscle that make up the posterior wall of the oropharynx. In this colorized arteriogram, look at the internal carotid artery, labeled 1. Posterior to the oropharynx, the artery should run straight up into the carotid canal to enter the skull. In a separate angiogram, however, one can see the potential for problems. The internal carotid artery should run straight posterior to the oropharynx, as shown on the left-hand panel. But now look at the location of an aneurysm, as shown on the right-hand panel, and recall precisely what is the anterior relationship of this aneurysm. Yes, the oropharynx. Imagine now performing a tonsillectomy of an extremely inflamed tonsil and inadvertently cutting behind the tonsillar bed in an individual with an aneurysm. The outcome could be an instant exsanguination. In addition to the aneurysms, there is a rare condition in which the internal carotid artery is tortuous instead of straight prior to entering the carotid canal. Again, imagine the possible consequences of performing a tonsillectomy on such an individual. And here's another example of an exceptionally large aneurysm to show you how large these aneurysms can become. Clearly, any relative benign procedure can have insidious consequences given the variations in the vascular system. This now concludes the second half of this lecture.